The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
So let's now proceed to cervical dysplasia and cervical cancer. So tapos na tayo sa ovarian masses and ovarian cancer. Ngayon naman cervix tayo. So ang ini-implicate lagi with the development of cervical cancer is HPV infection. So human papillomavirus, maraming serotypes yan. Okay, there's low risk serotypes or intermediate risk serotypes and high risk serotypes. Okay, yung HPV type 6, 11, 40, 41, 42 are low risk. So this can be seen in CIN1 or condyloma acuminata, genital warts. So ito ang mga ini-implicate for genital warts. Intermediate risks 31, 33, 35, 51, and 52 seen in HSIL, CIN2, or CIN3. Pag invasive CA, no, i-memorize ito 16, 18, 45, 58. Okay? Majority of cases are associated with infection of one or more types of HPV, which is sexually transmitted. So for genital warts or condyloma acuminata, it is caused by HPV, serotype 6 and 11. Okay, 90% yun yung nagkukos. 6, 11. These are raised papillomatous or spiked surface, pedunculated lesions, and cauliflower-like growths. Ganito. Ayan, medyo ano pa yan? Medyo subtle. Konti pa lang yung infection yan. Pero this is very infectious. No, yung mga lesions na yan, pwede yung dumami, maging ganito yung itsura niya. Cauliflower. So, ako as an OB, I've seen different types, no, of patients with genital warts. Yung mga nagtatrabaho sa mga nightclub. Ano na bang tawag ngayon sa ganon? Gentleman's bar. Yung mga ganon. Okay, so lagi yan siniscreen for genital warts, no? Or may mga tinitreat rin for genital warts. So very important, no, to use mga protection, no, to be able to prevent transmission of this genital warts. And of course, cervical cancer din for mga high risk. Okay? How do you treat? May 2 types of treatment. Pwedeng patient-administered, kasi syempre mahiyain yung iba, or pwedeng provider-administered. Patient-administered includes Podophilox, 0.5% solution or gel, or imiquimod cream, no, which is contraindicated in pregnant patients, yung imiquimod. Sobrang mahal lang ng mga to. No, pag binili mo yan sa Mercury, parang isang sachet na sobrang liit. Siguro mga 1 gram lang yun, 1 ml, ganyan. Around 700 pesos yung imiquimod. No? Ang mura is yung TCA. Pero itong TCA, ina-apply yan ng provider, ng doktor, or ng nurse, or kung sinong kayang mag-treat ng genital warts. Okay? So, how do you prevent? No? Prevent, of course, prevent natin yung mga sexual practices that can transmit, no, infection. Secondary prevention is cytology or pap smear. So again, pag sinabing pap smear, it's a secondary prevention of cervical cancer. These are the recommendations. Okay? Ang nasa blueprints pa is the ASCCP guidelines, yung cytology alone every 3 years starting at age 21 years old. Okay? Sa ACS 2020, feeling ko hindi pa rin ito itatanong ngayon eh. Ito yung pinakabago, no screening pag less than 25 years old. 25 years old yung start ng screening for sabi sa ACS 2020. Sa ASCS 2012, no, ito yung mga nasa books pa. Cytology alone every 3 years until age 29 years old. Ang preferred is HPV and cytology co-testing every 5 years. Acceptable is cytology alone every 3 years. Ang cytology co-testing, kasama dyan yung HPV. Okay? Yung mga serotypes ng HPV, kung positive or negative siya with high-risk mga HPV strains. Okay? So ito or ito. No, sa ACS guidelines, 25 years old. So kung tinanong sa boards kung kailan nagsa-start, no, tas wala naman doon na 25 years old, ito yung ginamit nila. So 21 years old. No more than younger than 21 years old unless pregnant. Kasi sa pregnant patients naman, 'di ba, nakasama doon sa first prenatal check-up ang cytology or ang pap smear. So ito yung pinakabagong guidelines. For management of cytologic atypia, no, ang makikita nyo, dinivide siya by age. This is 21 to 24 years old and more than 24 years old. So, isa pang kailangang age yung tandaan niyang 20 to 24 tsaka more than 24 years old. Pag hindi binigay yung age, no, usually, mga ang tanong dyan, it's either HCell or AskH, no? Kasi pareho lang yung gagawin mo dyan, colposcopy. Pero kung hindi rin binigay yung age, tapos ang tinanong sa inyo, ASCOS, no, cytology pa rin after 12 months. Kasi yun yung pareho. Okay? Pero pag may age, titingnan yung mabuti kung more than 24 years old or 21 to 24 years old. Okay? Pag ask us or atypical squamous cell with undetermined significance, reflex testing lang or repeat cytology after 12 months. Pag more than 24 years old, HPV testing and repeat cytology after 12 months. Ito or, ito and. Okay? Pag L-cell, no, low grade yan, repeat cytology after 12 months. Pag more than 24 years old, okay, pwedeng mag-colposcopy. Okay? Pag HPV negative, HPV positive, or HPV unknown, automatic colposcopy. Pag AskH, colposcopy. Pag HCell, colposcopy. Pag more than 24 years old, colposcopy with ECC, that's endocervical curettage or LEEP already. Pag atypical glandular cells, colposcopy with ECC and endometrial sampling kasi baka endometrial sample yung nakuha mo, hindi siya cervical lang. Pag atypical endometrial cells, endometrial endocervical curettage. Ito naman will tell you kung ano ang gagawin when you have an HPV result already, kung na-determine kung positive or negative for HPV. Okay? Pag negative yung HPV, tapos may pap results na mga to, okay, or yung previous result ay ito, this is what we'll do. No, by the 2012 guidelines. This is for the 2019 guidelines. So ito yung pinakabago. Okay? Pag positive, pansinin nyo, no? Tapos wala namang nakita sa pap smear, unknown yung HPV or negative yung HPV ng previous, no? Repeat pap test lang. So ito yung mga ganun siya basahin, ganun siya gawin, no? Ganun siya dun sa handout nyo, ito nandun yan. Okay? Pero pag positive for genotypes 16, 18, or both, kahit na walang nakita sa pap smear, walang kinalaman yung previous result, automatic you do colposcopy. Pag positive yung current, positive yung dati, kahit negative yung pap smear, you do colposcopy also. Okay? So pag may tinanong, tapos sa tingin nyo alanganin, ang pinakamadaling isagot ay colposcopy. Okay? So that is testmanship. So hindi lang yan yung table na yan, ito pa. So pwede nyo rin itong basahin. So mostly, colposcopy yung ginagawa. 'Di ba? So kung meron kang mga choices at may colposcopy doon, go for colposcopy. Okay? Basically, risk-based framework yon. No? Bakit natin kailangan yon? To expedite the treatment preferred, expedite the colposcopy. Colposcopy recommended. It's either repeat test in 1 year, repeat test in 3 years, or return to routine screening at 5-year intervals. Ito yung mga management nun. Ito yan. Ito yung nasa dulo. Yung 2019 guidelines. So, 6 lang yung kailangan yung i-memorize talaga. Depende sa risk. Okay? Doc, paulit-ulit yung colposcopy. Ano ba yung colposcopy? Colposcopy, basically, pagsilip sa cervix. Okay? Pag sinilip mo yung cervix using the colposcopy, the colposcope, no? Office-based technique para ma-diagnose mo ang cervical neoplasia. o yung mga cervical abnormalities. Ang makikita nyo kasi sa ultrasound, yung ASC-H, H-cell, L-cell, ganyan. Pero hindi nyo makikita yung degree, no? Yung level of involvement ng buong cervix. Okay? So, dito sa colposcopy, yung depth niya, makagagawa nyo through colposcopic guided biopsy. So, paano ba ginagawa ang colposcopy? You have to check, no? Pagsilip nyo sa colposcope na makikita nyo yung buong structure ng cervix, including, no, the transformation zone. Remember your cervix, forever nag-change, no? Ang loob ng cervix is columnar. Ang ectocervix is squamous. Okay? Yung between ng squamous at ng columnar cells is called the squamo-columnar junction. Okay? Yung between, ito yan. Ito yung squamous columnar junction. Okay? Squamous ang labas, columnar yung loob. Yung gitna nila is the squamo-columnar junction. No? Forever nagkakaroon ng squamous metaplasia, no, ang cervix from columnar to squamous. Kaya siya squamous metaplasia. Pag nag-move na siya, naging squamous na siya sa labas, yung original mo na squamo-columnar junction, syempre mas mas lalabas siya. 'Di ba? Between the new squamo-columnar junction and the original squamo-columnar junction is the transformation zone. Okay? The transformation zone is bounded by the original SCJ, the new SCJ, and the most distal crypt opening. Ito yan. Okay? So, yung nasa gitna nila is the transformation zone. Transformation zone siya because it is the area of metaplastic squamous epithelium. Nagiging squamous sila dyan sa area na yan. Dito rin sa mga crypts na yan, dyan pumapasok, okay, yung virus, yung HPV. Diyan nangyayari, aside from the squamous metaplasia, diyan nangyayari yung abnormalities, cellular abnormalities. Okay? With me so far. So, dapat pag nag-colposcopy ka, makikita mo yung lahat. Okay, so ire-report mo ngayon sa colposcopy report mo na adequate, satisfactory yung pagsilip mo dun sa transformation zone and sa buong cervix. After which, ire-report mo naman kung merong abnormal blood vessels. 'Di ba? So, gagamitin mo yung green filter because you will be able to see abnormal blood vessel patterns like your mosaic, your punctuated, and your atypical na mga blood vessels with the application of the green filter. Tapos, ire-report mo yan. Ang pag-report ng abnormalities in the cervix, gagawin mong clock yung cervix. So, let's say there are mosaic patterned blood vessels at the 12 to 3 o'clock position of the cervix. So, yun, mosaic. Pang-punctated, siguro ito 2 to 4. Ito 9 to 1 o'clock. At 9 to 1 o'clock position. So, ire-report mo yan, no, with the application of the green filter. After which, no, kung wala naman, no need to report. There are no abnormal blood vessels seen. Next principle is acetowhitening. Acetowhitening is addition of 3 to 5 acetic acid, and this depends on the amount of nuclear protein. Okay? Because when acetic acid is applied, no, to normal proteins and cytokeratins, no, when it is applied to normal squamous epithelium, minimal lang ang acetowhitening. Pero pag nag-prolonged ang acetowhitening, ibig sabihin yan, no, maraming nuclear proteins na meron, no? Eh, di ba ang mga abnormal cells, marami yung nuclear proteins nila? Di ba? As compared to the cytoplasm. So, ganun yung nangyayari dyan. So, ire-report mo rin yung mga acetowhitening. Ito, nasa 8 to 1 o'clock. Ganon ang pag-report yan. There is acetowhitening at the 8 to 9 o'clock, 8 to 1 o'clock position. Ganon siya. So, that is acetowhitening. Next naman, no, after nun, i-clean mo ulit siya with saline, no, mag-a-apply ka naman ng Schiller or Lugol's iodine. Okay? Lugol's iodine is a concentrated solution that reacts with the glycogen in normal squamous epithelium, making it appear dark brown. Kung kanina may uptake, no, may acetowhitening, ang normal cells dito, okay, merong uptake. Ang abnormal ang wala. Okay? Magiging brown sila, yung normal. Yung mga hindi naging brown, those are the abnormal cells. Okay? Those are the abnormal cells. Because, yung, ano yan ang iodine is glycogenophilic. Gusto nila ng iodine. Tama ba yun? Glycogenophilic. Basta yung normal squamous na may glycogen, meron silang uptake ng iodine. Pag walang uptake, little or walang glycogen, so malamang abnormal cells yun. So, ire-report mo rin yun. Ang pag-report naman ng colposcopy, syempre nakita mo na kung nasaan yung mga abnormal blood vessels, asan yung acetowhitening, asan yung uptake ng Lugol's iodine. Yung area na yun ang ipobiopsy mo. Okay? Either punch biopsy, kukunin mo yung area na yon. Yun yung tinatawag na colposcopic guided biopsy. Ang mga magiging report nun are either CIN1, CIN2, or CIN3. Okay? Your CIN are pre-malignant changes with histologic features of cellular immaturity, cellular disorganization, nuclear abnormalities, and increased mitotic activity. Okay? The severity of CIN is determined by the portion of epithelium showing disordered growth and development. So, ito yung mga classification niya. Okay, cellular dysplasia, CIN1, CIN2 or moderate dysplasia, lower 2/3 of the of the epithelium. Pag mas malalim pa doon, it's severe dysplasia. Formerly carcinoma in situ na to or CIS for CIN3. Syempre mga B, pag may mass na doon, pag may mass na doon, cervical cancer na yun talaga. Hindi mo na kailangan i-colposcopy yun. Ang mga kinocolposcopy lang, yung mga microscopic lesions. Okay? Microscopic lesions. Pag may mass na doon, biopsy mo na agad yung mass. Alright? So, management naman for CINs. Pwedeng ablative or excisional. Pag walang suspicion of glandular involvement or satisfactory yung colposcopy, biopsy confirms CIN1, abnormal cytology alone is not sufficient. Okay? Lesion does not involve the endocervical canal and negative endocervical curettage. You do cryotherapy or CO2 ablation. Dito sa ablation, wala kang specimen. Okay? Wala kang specimen. Kasi okay naman, hindi mo na siya kailangan. Pag kailangan mo ng specimen for further pathologic study, you do excisional. Yung excisional mga methods natin is loop, electrosurgical excision procedure or LEEP, or cold knife conization. Conization, parang gagawa ka ng cone. Mag-excise ka ng cone, at yun yung isi-send mo for patho. So that's the management of CIN lesions. Okay? Pag may mass na that is already cervical cancer, ayan, hindi mo na kailangan i-colposcopy yan. Okay? There are two major types of cervical cancer. It can be squamous cell, yung histologic type niya, squamous cell CA or adenocarcinoma. For squamous cell CA, arises from the ectocervix most commonly kasi squamous nga siya sa labas, 'di ba? So it's the most common, exophytic or cauliflower-like, like this one, and spread to adjacent tissues like vagina or uterus. Ang adenocarcinoma naman, paloob yung laki niya. Okay? It's endophytic or barrel-shaped and lymphatic yung spread. Alright, so that's for cervical cancer. This is the stage and the treatment. Okay, pag stage 1A1 tsaka 1A2, and hanggang 2A1, actually pwede ka pang mag-surgery. Radical hysterectomy with bilateral lymph node dissection with or without bilateral salpingo o oophorectomy. So, yun yung stage na pwede ang surgery hanggang 2A1. Otherwise, ang mainstay treatment is concurrent chemorad. Baka matanong yan. It's chemoradiation, chemotherapy and radiation therapy. Okay? Ang ginagawa ng radiation, pinapaliit niya yung mass. Alright? Chemotherapy. Chemotherapy and radiation. Concurrent, sabay, chemoradiation. Hanggang 2A1. Pwede ang surgery. Now, let's go to endometrial hyperplasia and endometrial cancer. This one I got from Blueprints. Okay, so the pre-malignant diseases of the endometrium is called endometrial intraepithelial neoplasia. Sabi sa Blueprints, there are two classification systems, the WHO and the International Endometrial Collaboration Group. Okay? So, ang ginagamit talaga natin dito is the WHO 94. So, this is the classification that we use. We have simple hyperplasia, complex hyperplasia, simple atypical hyperplasia, and complex atypical hyperplasia. Okay? So, this is for endometrial hyperplasia. Pag may cytologic atypia, mas nag-i-increase yung risk of endometrial cancer. Pag simple hyperplasia lang, there's only 1% risk. Complex hyperplasia without atypia is 3%. Pag simple atypical hyperplasia, it's 8%. And complex atypical hyperplasia, it's 29%. Nung nasa residency ako, wala na tong simple atypical hyperplasia kasi hindi naman nakakakita ng ganito talaga. No, it's either simple hyperplasia without atypia, complex hyperplasia with or without atypia. Pero dahil galing to sa blueprints, no, ang progression for endometrial cancer in percentage, 1, 3, 8, and 29. Okay? Ang hyperplasia ay hindi pa cancer. No? Pre-cancer. So, okay. So, also, the risk factors. No, risk factors for developing hyperplasia is endometrium. Excess exogenous estrogen used without progesterone. Dahil ano bang ginagawa ng estrogen again? Pinoproliferate niya yung endometrium, walang progesterone na magsa-stabilize ng endometrium. So, makapal at makapal lang siya. So, that is already a risk factor for hyperplasia. Nulliparity, okay? Diabetes mellitus, obesity, menstrual irregularities, elevated blood pressure, tamoxifen use, rectal cancer, alright, infertility history, unopposed estrogen, or menopause late more than 55 years old. So, usually dahil lang din sa estrogen tong mga to. Okay? So, ano bang itsura ng mga hyperplasia na yan? Pag simple hyperplasia, irregularly shaped yung glands, but there is abundant stroma in between glands. Okay? Marami pang stroma in between the glands, lined by pseudostratified tall columnar epithelium, and glands are separated by abundant cellular stroma. Pag crowded na siya, may complex glandular outlines with papillary intraluminal folding. Ito, ganito yung itsura niya. Halos wala ng stroma. Okay? Usually, that's complex hyperplasia. Pag may atypia, there's loss of polarity already. There's increase, nucleus cytoplasm ratio, irregular shape and size. The nucleoli is prominent and thick nuclear membrane. So, ito yung histologic features ng simple and complex hyperplasia and atypia. Okay, how do you treat? Depende. Alright, pag premenopausal or with poor surgical risk, pwedeng oral na medroxyprogesterone, no progesterone. Pwedeng yon. Okay, or vaginized progesterone, anything na progesterone. Pag postmenopausal, you do surgery. Okay, pero pag poor surgical candidates, pwedeng progesterone lang. Dahil ang problema mo, sobrang daming estrogen, bigyan mo ng progesterone. 'Di ba? Correct. There are two types, type 1 and type 2. Ang type 1, yan yung mga mababait. Ang type 2, ito yung mga medyo bad. Okay? Medyo bad. Sa mga, meron ngayon bago the 2023 na staging ng endometrial cancer. Sinabi niya doon lahat ng mga types ng cancer na parang high risk. Parang high risk na mga types ng cancer. No? So, bago yon, bagong staging yon. So, most probably, hindi naman yon maitatanong sa inyo. Pero just in case, no, yun yung, may bagong staging with endometrial cancer ang ginawa ng FIGO. So, that's just 2023. Okay? Pero suffice to say, yung mga type 1, yun yung mga mababait. Galing yan sa hyperplasia. Okay? Galing yan sa maraming estrogen. So, the estrogen receptors are usually positive and it has a better prognosis. Okay? Ang type 2, yung mga biglaan na lang, menopause na, wala na yung kinalaman sa estrogen. No? So, ito yung mga high risk. High grade pala, sorry. Ito yung mga high grade. So, like serous papillary. Yan. High grade mga tumors yan. Hindi maganda ang prognosis nila for type 2. Okay? So, sinama na tong grading na to sa staging of endometrial cancer. Okay? Ito yung dating staging kasi. Yung 1A, 1B, ngayon meron ng 1C, no? Pero ito yung aralin nyo. Kasi ito pa rin yung alam ng mga tao. Okay? Myometrial invasion, less than 50% is 1A. Myometrial invasion, more than 50% is 1B. Okay? Ang mainstay treatment, surgical treatment for endometrial cancer is EBISO, extrafacial hysterectomy. Okay? Extrafacial hysterectomy. Mag-iiba lang yan pag stage 2 dahil meron ka ng cervical stroma. Anong mainstay treatment? Surgical treatment for cervical CA? It's radical hysterectomy. So, sa stage 2 na may cervical stromal involvement, you do radical hysterectomy. Pero all the rest, extrafacial hysterectomy. Isang tip ko dito, no, paano nyo mamememorize yung stage 3, 3A, 3B, 3C. If there is adnexal involvement, A, adnexa, 3A yon. If there is vaginal, B, vagina, stage 3B yon. C are nodes, no, that's kulane. There, lymph nodes, kulane. Okay? C1 tsaka C2, ang iniisip ko dyan, pelvic nodes kasi, no? Pag pelvic nodes, C1, C2, para aortic nodes, hindi sila alphabetical. Yung para aortic nodes, C2 yon. Pelvic node C1. Kung mas malito kayo doon, wag nyo nang i-memorize yun ng gano'n. Okay? Basta stage 4, laging beyond the gyne organs. Pag distal mets, 4B. So, pwede nyo ring i-drawing yan or pwede nyo isulat. Mas madali siyang i-memorize kesa i-drawing. Okay? Pero kung gusto nyo i-drawing, kung ganun kayo matuto, go ahead. Drawing nyo. Now, let's go to infections. Tapos na tayo sa malignancy. Let's go to the infections. So, infections of upper genital tract. No, taas. I'll just present you two, endometritis and PID. Endometritis is infection of the endometrium. Pag sinabi mong endomyometritis, infection invades the myometrium already. Endomyometritis. Pag chronic endometritis, it is often asymptomatic but may lead to other pelvic infections. It can be suspected if with chronic irregular yung bleeding, may discharge, may pelvic pain, and it can only be diagnosed actually with endometrial biopsies showing plasma cell. Okay, so endometritis. How do you treat? You give clindamycin, no, or cefoxitin with gentamicin. So IV ang treatment niya. So treatment course continues, yung IV, until clinical improvement and a febrile status for 24 to 48 hours. Oral antibiotic therapy is not required following successful parenteral treatment. In non-puerperal infections, ibig sabihin, hindi naman siya postpartum. Yung chlamydial infection may be suspected, you give doxycycline. Marami talagang ini-infect yung chlamydia. No? Pag chronic endometritis, again, you give doxycycline. Now, kung umakyat na yung infection, naging pelvic inflammatory disease na siya. Okay? It is an infection of the upper genital tract, including a combination of endometritis, salpingitis, tubo-ovarian abscess or TOA, and pelvic peritonitis. So traditionally, ang sinasabi nila, associated to with chlamydial infection. Pero they found out now na maraming types ng bacteria talaga ang pwedeng mag-cause ng PID. So ang nangyayari dyan, the risk factors mo, of course, multiple sexual partners, no, STDs, IUD use, or inducing, nagkakaroon ng disruption of vaginal ecosystem and endocervical barrier, pwedeng mag-lead into ascending infection. Magsa-start yan as cervicitis, followed by endometritis, yung diniscuss natin kanina, and then salpingitis. Pwede niyang sirain ang tubes. Pwede kang mag-cause ng hydrosalpinx. Okay? And then, pwede rin niyang ma-infect ang ovaries, and eventually, kahit yung peritoneum, pwede niyang ma-infect. Okay? So, spectrum ang PID. So, the risk factors for developing PID, of course, is exposure to sexually transmitted infections, no? And, of course, age at first coitus, marital status, and number of sexual partners. Usually, yung mga young-aged patients, no? Actually, malaking, meron akong ganitong story. Hindi ako. May patient ako, 18 years old. So, sabi niya, wala pa siyang sexual partner. So, parang in-ultrasound. So, ang base sa ultrasound, dahil wala pang sexual partner, no, transrectal pa yung ginawa sa kanya, ang ultrasound niya was bilateral na ovarian mass. Okay? So, pag ganon, kailangan mong tingnan kung anong klaseng mass yun kasi bilateral eh. So, we scheduled her for OR. Ganyan. Nung in-OR siya, syempre inopen, pagkita, walang mass ang ovary. Ang meron lang are bilateral hydrosalpinges. So, so ang ginawa, syempre hindi mo naman tinanggal yon, no? Yung, kasi tiningnan kung patent yung mga fallopian tubes, kung kaya pa siyang isave, wala na talaga. So, nag-bilateral salpingectomy na doon. Okay? Bilateral salpingectomy. So, parang medyo napagalitan ako kasi I was the senior in the case. Tapos sabi niya, hindi mo ba tiningnan yung vagina? 'Di ba? Kasi ako, naniwala ako dun sa patient na wala talaga siyang sexual contact. Okay? So, minsan, mahirap talagang maniwala sa mga patients kasi magkaka-hydrosalpinges ka lang if you have PID, if you have infection. So, true enough, nung pagising niya, tinanong namin siya, no, kung nagkaroon na siya ng sexual intercourse. Sabi niya, since she was 15 years old, so umamin na siya nung time na yon. Okay? Umamin na siya nung time na yon. Sayang, kasi naoperahan pa siya. Pwede naman sana siyang hindi naoperahan. Okay? Nung time na yon. Pero na-open na kasi siya eh. 'Di ba? So, in-explain na lang namin sa parents niya kung anong pwedeng mangyari. Kasi IVF mo na lang yon. Bilateral hydrosalpinges. Okay? So, yun ang moral lesson of the story. Minsan, tingnan mo kung meron talagang lacerations na, no, na healed sa vagina. Kung medyo alanganin ka. Siyempre, naniwala rin kami sa ultrasound. Naniwala rin kami dun sa patient. Okay, the signs and symptoms of PID minsan non-specific, but the most common is new onset lower abdominal and pelvic pain. So 5 to 10% of women with acute PID develop symptoms of perihepatic inflammation, the Fitzhugh-Curtis syndrome. Kaya kung may PID, sumasakit din yung right, no? Kasi meron ng mga adhesions in the liver capsule. Okay, so that's Fitzhugh-Curtis syndrome already. It is characterized by right upper quadrant pain, pleuritic, tender, no? When the liver is palpated, the pain may radiate to the shoulder or to the back. No, liver transaminases may be elevated. So ito yung chronic PID with adhesions, the Fitzhugh-Curtis syndrome sa capsule ng liver. And this is tubo-ovarian abscess. Tubo-ovarian abscess, tube, fallopian tube, ovary. Meron doon na abscess, tubo-ovarian abscess. Okay? So, kasama rin yun sa PID. Ang tubo-ovarian abscess actually is a radiologic diagnosis. It's an ultrasound diagnosis. Makikita mo kasi siya sa ultrasound. Pero ang diagnosis pa rin nun is PID. So, minimum criteria for the diagnosis of PID is lower abdominal tenderness or adnexal tenderness or cervical motion tenderness. Additional criteria, okay, may fever 38 degrees, may discharge, WBC on vaginal secretion, elevated ESR, elevated CRP, laboratory documentation of cervical infection with gonorrhea or chlamydia trachomatis. But the definitive criteria is a histologic evidence of endometritis in endometrial biopsy. Okay? Meron ka rin na TVS, pwede rin, and laparoscopic abnormalities that are consistent with PIDs. Pero the criteria for hospitalization, pag surgical emergencies, hindi mo alam, baka mamaya appendicitis pala yun, no? So, pwede kang mag-operate. When there's tubo-ovarian abscess, pwede mong i-admit. Pag may tubo-ovarian abscess, automatic, you have to admit kasi IV ang antibiotics niyan. When the patient is pregnant, when there is severe illness, unable to follow or tolerate outpatient oral regimen, or no clinical response to oral antimicrobial therapy. So these are the treatment, no? Ito na yung pinakabago sa treatment of PID. Okay? Ceftriaxone, 500 milligrams. Pag medyo chubby, pag more than 150 milligrams, 1 gram na ceftriaxone na IM ang binibigay, plus doxycycline, with or without metronidazole. Okay? Pag parenteral, ito rin yan. Alright? Kanina, dinuscuss natin ang tubo-ovarian abscess. Tubo-ovarian abscess, again, sa radiologic diagnosis, pyosalpinx, PID pa din yan. This is a sequelae of persistent PID. The tubo-ovarian complexes are not walled off like true abscesses and thus more responsive to antimicrobial therapy. Pag yung TOA, hindi siya ganun ka-responsive, no? The progression from PID to TOA is around 3 to 16% pag hindi na-treat ng PID. HIV-infected women with PID are at risk, increased risk for developing TOA. So a TOA can be diagnosed by ultrasound. It appears as a complex or cystic mass, can be unilateral or bilateral. Okay, yung Piosalpinx, ito siya, oh. Ayan. A Piosalpinx may be seen as elongated, dilated, fluid-filled with partial septae and thick walls. Alright. So ito yung mga ultrasound findings, no, with tubo-ovarian abscess. Pag narinig nyo yung cogwheel appearance, no, cogwheel sign, most probably it is PID. Okay? Kasi may mga nagtithicken yung endosalpingeal folds eh. Sa ultrasound, hindi nyo makikita ang fallopian tube unless may problema ang fallopian tube. Okay? Diagnosis. Okay, again, clinical, ang diagnosis ng PID because 90% will complain of abdominal or pelvic pain, 60 to 80% will have fever. Culture swab, you have to do this to rule out sepsis. Yung coldosynthesis, pagkuha mo, no, ang makikita mo doon gross pus, pero hindi na natin yan ginagawa. Ultrasound is the imaging study of choice. You treat it, medical, okay, surgical for more serious TOA. Okay? Or ultrasound-guided drainage of the TOA. Pwedeng unilateral salpingo-oophorectomy. This is curative therapy for unilateral TOA. Or tabiso for bilateral TOA. No? Tabiso, bakit dok tinanggal pa yung uterus? Wala nang gagawin yung uterus doon kung wala nang ovaries, di ba? Tambay lang siya doon. So, tanggalin mo na din. Okay, the treatment for TOA, same as PID. We'll now go to the infections of the lower genital tract. So one way to classify these infections is whether they are non-ulcerative, genital ulcers, vaginitis, or mucopurulent cervicitis. So this is one way, no, to categorize these lesions. Pag non-ulcerative, usually yan mga infestations like your pediculosis, your scabies, no, your molluscum contagiosum, and condyloma acuminata. Ito infections naman yung dalawa. Pag genital ulcers, may ulcer, syphilis, herpes, chancroid, and lymphogranuloma venereum. Pag vaginitis, mga discharge, bacterial vaginosis, trichomoniasis, or candidiasis. Okay, pag mucopurulent cervicitis, no, greenish yung discharge, Neisseria gonorrhea and Chlamydia trachomatis ang mga etiologic agents. Another way to classify this is drips and sores. Drips are the discharge. Gonorrhea, chlamydia, mucopurulent cervicitis, candidiasis, or trichomoniasis. So, yun yung mga drips. Sores naman, your ulcers can be classified into painful or painless. Pag painful, yun yung mga herpes, chancroid. Pag painless, syphilis, LGV, and granuloma inguinale. So, those are the ways to classify mga lower genital tract infections. Okay, the sexually transmitted infectious vulvar ulcers naman, your herpes, syphilis, chancroid, and LGV. Pag non-infectious na vulvar ulcers, no, baka biglang masama to. Your Crohn's disease, iba yan sa Crohn's disease. Crohn's disease, these are knife-cut vulvar ulcers. Okay, as its first manifestation, preceding GI or other systemic manifestation by months to year. And of course, you have your Behçet disease, leads to tender and highly destructive vulvar lesions that often cause fenestrations in the labia and extensive scarring. So, ito yung Crohn's disease. Okay? Crohn's, yan. Knife-cut lesions. Crohn's disease. Ang Behçet disease, no, it's a recurrent multisystemic inflammatory disorder of unknown etiology characterized by a triad of oral ulcers, genital ulcers, and ocular lesions. Okay? So, yun yung mga ulcerative. Pag non-ulcerative, your pediculosis, your scabies, your molluscum contagiosum, and your condyloma acuminata. So, as a summary, ito yung table na yan. Kailangan nyo lang malaman, pediculosis or lice, no? Vulvar lice. Kuto, mga B, crab louse, yan. Most contagious of all STIs. No, madikit ka lang dyan, pwedeng mahawa ka of pediculosis. Alright? Ang scabies, pathognomonic niyan, is the burrow in the skin. Usually, makati yan sa gabi. Okay? Actually, makati siya buong araw, pero mas pronounce yung kati niya sa gabi kasi syempre tulog ka. Okay? Your molluscum contagiosum is caused by the pox virus, dome-shaped papules with umbilicated center. So, pag nabasa nyo yung umbilicated center, molluscum contagiosum, i-consider nyo yan. Condyloma acuminata, it's the most common viral STD of the vulva, vagina, rectum, and cervix. Okay, most contagious again, pediculosis, burrow, scabies, umbilicated center, molluscum contagiosum, and most common viral STD is condyloma acuminata. Warts. Okay, so yan yung mga non-ulcers. Pag yung mga ulcers, ito yan, syphilis, herpes, chancroid, and LGV. So this is the summary of your ulcerated lesions. Sa-isahin natin yan. Syphilis, again, chancre, ang primary lesion yan. It is painless ulcer that heals spontaneously. Pag secondary syphilis, it's already a systemic disease with rashes and condyloma latum. No? Condyloma latum. Hindi yan condyloma acuminata. Condyloma latum associated with painless adenopathy. Tapos magkakaroon ka ng latent phase, positive, no? Yung serology of syphilis pero wala kang signs. Pwedeng progress yan into tertiary and late syphilis. Pag gumas, narinig mo yung gumas, it's already late syphilis. Cold abscess with necrotic center. So there's already necrosis pag yung guma. Okay? Pero dahil double M, baka gamma. Gamma siya. No? Pero nasanay tayo guma. Sige na nga. Push natin yan. Okay, how do you transmit? Of course, sexual contact, oral genital contact. You're screened by VDRL or RPR, but the definitive diagnosis is to dark field microscopy where you can see thin, silvery, spiral, motile organisms, your treponema. Okay, you treat by penicillin. Okay, so yan pa rin ang primary, yan pa rin ang gamot for primary, secondary, and early latent syphilis. Penicillin G. Herpes. Herpes transmitted through asymptomatic shedding. It is recurrent, incurable, and highly contagious. Okay, the first sign of herpes, may paresthesia of the vulvar skin. Okay, papule and vesicle formation, severe vulvar pain, tender and inguinal adenopathy, and general malaise and fever. Ang mga recurrent episode niya, hindi na ganun kalala than the primary episode. Okay? Definitive diagnosis is through PCR. Okay? It is the most accurate and sensitive. Okay? That's for herpes. You treat herpes with valacyclovir, acyclovir, and famciclovir. Okay? If you can see here, the first clinical episode, medyo matataas no yung binibigay. Okay? Pag mga recurrent episode, 5 days na lang. For valacyclovir to ha. Usually, yung binibigay ko talaga valacyclovir eh. More than acyclovir. Kasi, tingnan mo, 5 times a day yung acyclovir, nakakatamad naman uminom nun. Okay? So, pero pwede ha, valacyclovir, acyclovir, or famciclovir. Okay? Pag recurrent, no more than 9 recurrences of herpes infection in a year, you give 1,000 milligrams, okay, for more than 10 recurrences per year or 500 milligrams daily. This is for daily suppressive therapy for herpes. So, ganito yung mga itsura niyan. For syphilis ito, no? Primary, secondary, the condyloma lata, and tertiary. So, syphilis to ha. Okay? Ito yung secondary, may mga rashes siya over the palms of the hands, soles of the feet, back. Okay? So tertiary, ito yung guma. Necrotic na siya. Magfo-fall off na yung penis. Okay? So nakakatakot. For vaginitis naman, these are the drips. Okay, the vaginal bacterial vaginosis, trichomoniasis, and candidiasis. Bacterial vaginosis, ang itsura ng discharge niya, thin, whitish gray, homogeneous with a fishy smelling discharge. You give oral metronidazole. Ayan, clue cells. No? Inclusion cells na may mga bacteria, those are your clue cells. Your trichomoniasis, no? Yellow frothy discharge. Yung isa white gray homogeneous, ang trichomoniasis yellow frothy, no? Usually associated with the strawberry cervix. Yan, yun yung mga lesions. Okay? And you also give oral metronidazole. For candidiasis, white thick curdy makate, no? Intense pruritus yan. You give topical antifungal drugs, oral fluconazole single dose. But fluconazole is contraindicated to pregnant women. Isa pang drip, no, is mucopurulent cervicitis caused by Neisseria gonorrhea or Chlamydia trachomatis, no? It's sexually transmitted. The gold standard is NAAT, no, for the diagnosis. For chlamydia, you give azithromycin or doxycycline. For gonorrhea, give ceftriaxone or cefixime. Okay? So all this, trichomoniasis and mucopurulent cervicitis are sexually transmitted. Bacterial vaginosis, hindi siya sexually transmitted but it is sexually associated. What do you mean by sexually associated? The more chorva, the more chances of winning. Bacterial vaginosis. Okay? Hindi naman kailangan i-treat yung partner. No? So, sexually associated lang siya. Candidiasis is not sexually transmitted. Okay? So, isa-isahin natin bacterial vaginosis. It reflects a shift in the flora from good bacteria, the Lactobacilli dominant, to mixed flora, usually Gardnerella vaginalis. No causative agent has been identified. It is sexually associated, especially with those with new or multiple sexual partners, women who have sex with women, douching at least monthly or within the prior 7 days, all right, or social stressors. You diagnose this, ang gold standard is gram stain. At low resource setting, you can do Amsel's criteria. You treat this with metro or clindamycin. Okay? So, ang diagnosis niya, gram stain, presence of clue cells, and decreased number of lactobacilli. That's your Nugent's criteria. So, this is the gold standard. So, ibig sabihin, pag Nugent's criteria, predominant na ang Gardnerella vaginalis. Okay? Predominant na ang Gardnerella vaginalis. So, 7 to 10 points is already bacterial vaginosis. Okay? Otherwise, hindi pa. Pag normal, hindi siya bacterial vaginosis. You have to look at other entities. Also, Amsel's criteria for low resource setting, dapat may homogeneous vaginal discharge. The pH of the discharge is more than 4.5 kasi wala nang lactobacillus, diba? There's a mean-like odor when mixed with KOH, which is also called the whiff test. Baka matanong sa inyo yung whiff test. The wet smear demonstrate clue cells greater in number than 20% of the vaginal epithelial cells. Again, clue cells are vaginal epithelial cells with bacteria inside them. Okay? So, this is for low resource setting kung walang gram stain. How do you treat? Metronidazole 500 mg twice daily for 7 days. Pwede ring gel or pwede ring clindamycin. Okay? Alternative regimen actually ang clindamycin. Pero mas preferred ko pa rin ang metronidazole. Next, trichomoniasis. Etiologic agent is Trichomonas vaginalis. These are unicellular, intracellular, anaerobic flagellated protozoa na makikita mo through wet smear. So, makikita mo ng mga trichomonads, galaw-galaw sila doon. Okay? Pag frothy yung discharge with unpleasant odor, with strawberry cervix, no, vulvar pruritus, and dysuria, think of trichomoniasis. You treat them usually with the drug of choice is metronidazole 500 mg twice a day for 7 days. For men, no, you give 2 grams single dose of metronidazole. Dati kasi naging DOC din ang metronidazole na 2 grams for women. So, binago na nila yon. So, for men na lang siya. Okay? Kasi masakit sa tiyan ang metronidazole na 2 grams. Kung na-try nyo na yan, masakit talaga siya sa tiyan. Okay? So, 500 milligrams twice a day na lang for 7 days. Di ko pa na-try. Chinika lang sa akin. Huwag kayong ano. Next, candidiasis. The etiologic agent for candidiasis is Candida albicans or yung mga Candida species natin. Okay? It can be uncomplicated, sporadic lang, infrequent, mild to moderate, no? Likely si albicans lang 'yan, no? Natagalan lang yung underwear, yung mga ganyan kasi usually nagko-cause yan ng fungal infection eh. Pag makate, there's vulvar burning, extensive dysuria or dyspareunia, think of candidiasis. No, you diagnose it by addition of KOH, makakakita ka ng filamentous forms, mycelia, hyphae, pseudohyphae, no? You can also do culture with Nickerson or Soborod medium. You treat this with either intravaginal regimen or oral fluconazole. Okay? Pag recurrent, doc, kasi usually ang mga fungal infections recurrent, 'di ba? Okay, pag recurrent, lalo na for mga immunocompromised patients with diabetes, yan, laging nagkakaroon ng vulvar candidiasis yan. Initial therapy, pag 4 or more episodes of symptomatic vulvovaginal candidiasis within 1 year, you give 7 to 14 days of topical therapy or 100, 150, or 200 milligrams of oral dose of fluconazole every third day for a total of 3 doses. Ang suppressive maintenance therapy, oral fluconazole, weekly for 6 months. Okay, so now let's go to mucopurulent cervicitis. It can either be Neisseria gonorrhea or Chlamydia trachomatis. Yan yung mga etiologic agents niyan. No, greenish yung discharge. Okay, usually associated with PID rin. Okay, pag cervicitis pa lang siya. Okay, inflammatory process associated with trauma, inflammation, systemic disease, neoplasia, and infection. So, yun yung cervicitis. Pag ectocervicitis, severe vaginitis, pwede rin magkaroon ng strawberry cervix, which is associated with T. vaginalis or C. albicans. Pag endocervicitis, no, endocervicitis sa loob na. Usually yan, Chlamydia trachomatis or Neisseria gonorrhea, bacterial vaginosis, or Mycoplasma genitalium. So, yun yung mga pwede niyang etiologic agent. So, cervicitis, pwedeng loob, pwedeng labas. Pag mucopurulent na yung cervicitis, usually yan, Neisseria and Chlamydia. So, makikita mo yan, there's gross visualization of yellow mucopurulent material on a white cotton swab. Okay? Ang usual pathogens, Chlamydia and Neisseria gonorrhea. Okay? Sabi sa CDC in 2021, the treatment is ceftriaxone 500 milligrams IM, 1 gram for those weighing more than 150 kilograms. This is for Neisseria gonorrhea. The gold standard for diagnosis is still NAAT. Okay? In microscopy, makakakita ka ng dun sa swab, endocervical swab, ng gram-negative intracellular diplococci. Sa gram stain, hindi mo makikita ang chlamydia. Ang makikita mo lang doon is gonorrhea. So, you treat the gonorrhea with ceftriaxone. Pag may mucopurulent cervicitis ka, negative ang gram stain mo, most probably it's chlamydia. So, you give doxycycline 100 mg BID for 7 days. Okay? So, pag meron kang Neisseria gonorrhea, gonorrheal infection, no, i-cover mo na rin ang chlamydia kung hindi mo siya nakita sa gram stain or wala kang naat. Pero kung may naat ka, no, tapos wala namang chlamydia, no need to give doxycycline. Okay? As treatment for chlamydia. So guys, that ends our lecture in gynecology. So I hope you learned a lot. You learned the basic na kahit ikot-ikutin kayo, no, meron kayo at merong masasagot. I'll be praying for all of you for all your success. I will see you, no, sa ating mga susunod na lectures. If you have questions, you can message me. You guys have my number. All right? Bye everyone.